Hello there. You're listening to Scraps and Stories, a podcast that brings you real and relatable stories from what life in healthcare really looks like. Today's episode, I'm very honored to have the very first doctor on the podcast. Dr. Michael Kozlowski is a palliative care specialist dedicated to delivering patient-centered care across multiple settings. He currently serves as an attending physician in a home hospice, practices as a general practitioner, and holds the position of Vice Chief of Palliative Care at Jagiellonian University Hospital. Beyond his clinical roles, Dr. Kozlowski is also involved in medical education, teaching both the Polish and international students at Jagiellonian University. Through these roles, he plays such a key role of shaping the future of medicine, and it is truly an honor to have him here to share his insights and experiences with us. Dr. Kozlowski, thank you so much for joining us today.
Thank you. It's really a pleasure to be with you here today.
Thank you. I was trying to compile a few questions that I would ask you as a palliative care specialist. I feel like the field of palliative care medicine is very broad and there's so many things to learn from it. And also itself, it comes with a lot of misconceptions. A lot of people look at it in different ways. They have different definitions of palliative care medicine. But before we get into the broad picture of what palliative care medicine, I'm very curious to know your journey to medicine. What was that like? What's your story to medicine?
I was actually thinking about this question in the car driving here, that I expected to be asked it. I will tell you that I wanted to become a physician since I was very young. When I was about 10, my grandfather was dying of Alzheimer's disease. Dementia, and I saw firsthand sort of the physical and psychological toll this took on my grandmother and my mother. And this was I think, even as a child, a big sort of motivation for me to think about medicine and I wanted to help people like my grandmother and mother. Then, of course, as I got older, I wanted to do something very exciting in medicine, such as surgery. I even thought about neurosurgery, something really intense. But then, however, as time went on, my focus became more on, of course, palliative medicine.
Oh, that's very great. The fact that you had this from a very young age, you have this drive of helping people. Has it always shaped? Do you feel like it has always guided you to palliative care medicine, or has it always been a broad perspective throughout your medical school?
I think it was more of a broad perspective.
Mm-hmm.
I did not go to medical school even knowing what palliative medicine is.
Mm-hmm.
And of course, I think as a young medical student, I sort of had the tendency maybe to look, really being focused on saving patients' lives, making them healthy, because that's what you're sort of trained to do in medical school. But then as time went on, I became sort of more and more exposed to patients who were dying, who had incurable diseases. And I began to sort of think, how best can I help these patients? Mm-hmm. But I also think that I saw that they were not being, they were lacking sort of specialized symptomatic care, and the sort of comfort care that palliative medicine offers. But I think at the beginning, I really didn't know that something like that was called palliative medicine, right? So.
Right. And how was your journey through med school? I know you were born and raised in the US. Mm-hmm. How did you move to Poland? What made you come to Poland for medical school?
I will tell you that after my great-grandmother died, when I was in my junior year in high school, she was born in Poland and immigrated to the United States. And I started to become very interested in my heritage. Mm-hmm. I started to read lots of books about Polish history. I even started to learn the Polish language. And of course, I always wanted to become a physician. So my plan was to first study Polish language and culture at the University of Pittsburgh, where I'm from, and then go on to medical school after that. But then I discovered that the Jagiellonian University offers a program of medicine in English, so I decided that I could sort of kill two birds with one stone by studying medicine here and, of course, experiencing life in Poland firsthand. And then, as I told you earlier, it was a cascade of various professional and personal events that resulted in my decision to stay here permanently.
Okay. By the time you moved to Poland, were you able to speak Polish fluently, or did you have to learn when you got here?
No. I had to learn here. It was very, very difficult road. Mm-hmm. Of course, I mastered things like food, and I could do shopping and things. But then the medical Polish, this was a whole nother process. When I decided to stay for my internship, I had to pass the Polish medical language exam. And even when I started my internship, my Polish was not where it should have been. But of course, it's either sink or swim. Yes. So I had to simply manage.
I'm kind of very curious about that process for you as well, because a lot of medical students, English division specifically, when they usually think maybe staying in Poland is not an option because probably they don't speak Polish that fluently, or what the process would look like for them if they wanted to stay there, to stay here, I mean. So could you please take us through what that process of staying in Poland was? Did you have to do like any board exams? What was that process like for you?
Absolutely. I will tell you, though, that a lot has changed in the 10 years since I went through the process. But essentially, when you want to start your internship, you must prove knowledge of the Polish language in the medical setting. So there's a special exam run in Warsaw by the National Chamber of Polish Physicians that you have to pass.
Is that the LEK exam?
No, this is not the LEK exam. This is strictly a language exam.
Okay.
It's composed of written portions, of spoken portions. It's quite difficult. Then you are allowed to start your internship, and during your internship or after you finish your internship, you then have to pass the LEK exam. This in Polish is lekarskie egzamin końcowy, which you can either pass in Polish or English. However, the English version is very poorly translated, I must tell you. At least it was 10 years ago. So usually it was I'm talking about us as the foreigners, were looking at both the Polish version and the English version of a question in order to really figure out what was going on here, what they were looking for. And then after that, after you have finished your internship and you've passed your LEK exam, you then can get your unrestricted medical license, and you can then apply for your specialization training.
So the internship comes before the LEK exam?
Yes.
Okay, because I saw some students doing the LEK exam in the 5th year of medicine, so I didn't know if that was like compulsory to do it before you finish medicine or after.
I will tell you that again, this was 10 years ago, you could take it during your internship or after you'd finished. I'm not sure if the process hasn't changed. And maybe now you can take even the LEK exam on your last year of medical school. There are also practice LEK exams you can take beforehand. So the process is, of course, very dynamic.
Yes, okay. And after you finish the internship and the LEK exam, now you get your license to practice.
Yes, and you could, for instance, after having this license, you could work as a GP. You could do many other things where they do not require a specialization. But then, of course, most doctors will then decide to do residency training in a particular field.
Okay, and how is that residency program? What does that look like from transitioning from a GP, a general practitioner, to go into residency? Do you have to do any other exams?
Yes, and
Mhm.
then, well, I mean, between your internship and your residency, no, there are
Mhm.
no other exams. You apply for your residency based on your results on the LEC exam.
Mhm.
However, when you finish your residency, you have to pass your national specialization exam.
Mhm.
And this is, I would say, hardcore,
Okay.
especially for someone who is having Polish as a second language.
True. Okay, so do you think it would be, from your own perspective and from your own experience, do you think it's very possible and it's easy for someone who studied in English, fully in English, to go through that process of integrating themselves in Poland? Uh, do you think it's easy, that process is, maybe it might not be easy, but from your own experience, would you encourage someone to look into that?
Um, I don't know if I would encourage them. I will tell you that it's absolutely doable, but it takes a lot of hard work, a lot of sacrifice, and you have to be thinking about, why do you want to do this? So for me, it was an easy choice because of my Polish background and because of various also personal reasons. But for someone who maybe is, has no real connection with Poland, it can be very difficult and not necessarily the best choice, in my opinion.
I get it. But moving back to your experience through med school, I'm curious because this university is a very old university and there's so many generations. Sometimes we were taught by teachers who were also in the same university like you. I'm curious to know what med school was like at that time. Do you feel like there's a huge difference now in the way maybe classes are conducted or the lifestyle in med school? Do you feel like it's different now?
Um,
Very different now?
I don't think it's so different. I don't think it's so different. I mean, certain things have changed. Obviously, the facilities now are much better. I don't, you now as students have a student's cloakroom where you can have a locker and things. I remember when I was a student, we were having a lot of classes on the Copernicus Street or, pediatrics here in Prokocim. And I remember the, giant cloakrooms where you just threw your stuff on the floor and there was no really anywhere to change. And so the facilities now for me as well as a physician, but also for students is much better. Even the fact that every ward has their own seminar room, which makes it comfortable for students and also very comfortable for lecturers as well. But I think the general program has much stayed the same.
Okay. Oh, that's very nice because to know because you as a student now you tend to think, oh, was it like this 10 years ago or 20 years ago? Did they also experience the same things we're going through? And it's nice to know that it's sort of the same thing as well. It's not now that we've talked about pretty much your medical journey and what that looked like. Maybe we can now jump into the residency program and you deciding to go for palliative care. Could you please take us through what that journey, what inspired you to pursue residency in palliative care?
Of course. I will tell you that during my medical studies, of course, the whole adaptation process is very difficult, especially in a foreign country. And I really wasn't sure what I wanted to do. I was jumping around. First, I wanted to be a surgeon, then I wanted to be a pathologist, even, which is quite on the other extreme from palliative medicine. And finally, I started to sort of uh, read a little bit about what is palliative medicine. And also, when I started my clinical classes, I started to have exposure to patients with these terminal life limiting conditions. And I also saw a lot of sort of futile and persistent therapy being used. When treating these patients. And even as a student, I sort of felt a bit allergic to it, I would say, and thinking I didn't always see the sense of giving chemotherapy and intensive treatment to patients who were very close to death and in whom these treatments really didn't offer any clear benefit to them, especially when many of these treatments were causing them symptoms and actually worsening their quality of life. Yes. So I think this sort of drove me to explore the field of palliative medicine more. I will tell you that when I studied, there was no course of palliative medicine for English language students here. So I contacted the director of the palliative medicine department, who is now one of my great mentors. And she was my mentor throughout the whole process of palliative care training. And I asked her, could I come observe, shadow her work on the ward? And I did that in my fourth year. I believe it was the second half of my fourth year. And I would say really right away after going on ward rounds with them, I sort of felt that palliative medicine was my calling. And this was what I was supposed to do with my life. And I immediately was drawn to their approach to the patients, the empathy that all of the physicians and nurses showed towards the patients, and the whole sort of philosophy of care. So I think right away I knew that palliative medicine was for me, and I just sort of got deeper and deeper and deeper into it. And things sort of just maybe snowballed out of control, where I was so involved with palliative care that there was nothing else I could do with my professional career. And then, of course, I made the decision to do my internship here, and I had the intention of going back to the States after that. And first doing residency in internal medicine and then fellowship in palliative medicine, which is how the American system of training looks like. However, sort of things, again, spiraled out of control. I started to do my PhD, and then I finished my PhD, and then I was already in my residency in palliative medicine. So I made the conscious decision to stay here in Poland and, of course, to continue working in palliative medicine.
Okay. So right after med school, you already knew you wanted to do palliative care.
Yes. I would say I was sure about it from my fifth year onwards, that palliative medicine was my choice.
Yes.
And the only, I would say, thing to be decided was how I was going to achieve that. And, of course, where I was going to be practicing palliative medicine.
Great. Before we get deep into it, a lot of people don't know what palliative care medicine is. And those who know it, a lot of them probably think it's only dealing with terminally ill patients or end-of-life care. How would you best describe what palliative care it really is, and what kind of patients are in need of palliative care?
Of course. It's very good you said that, because yes, there is a sort of widespread perception, both amongst the public, but also amongst our colleagues from other specialties, that palliative care is only for those who are imminently dying, for those patients who have a very short time left to live. However, palliative care, we like to talk about the term life-limiting diseases. Terminal diseases are that term has fallen out of fashion because of the fact that we want to offer palliative medicine to patients at any point on the disease spectrum, from diagnosis up until death. And it's important to think, of course, we generally think about cancers as being sort of the most commonly seen diseases in palliative medicine, but really many other diseases too. So we're thinking about things like congestive heart failure, COPD, pulmonary fibrosis, other even renal chronic kidney disease, liver cirrhosis. All of these things these patients could benefit very much from palliative medicine, receiving palliative care. However, we're not really talking about these diseases as being terminal diseases, because many times the course of disease can be much slower, much more slowly developing, and these patients can live for years or even decades. But we're still talking about this life-limiting disease.
Okay.
It's also important to remember that with palliative care, we are focusing on relieving the patient's symptoms rather than treating their disease. However, this is not mutually exclusive together with curative therapy. So patients can still receive chemotherapy. They can still receive, cardiological specialist care and things like that, while also receiving symptomatic palliative care. So generally, when we're talking about a patient who's a bit earlier in the disease course, we're talking about, we usually use the term supportive care. So supportive care, for instance, when we're talking about an oncological patient who's still receiving chemotherapy, which could even be potentially curative chemotherapy, but these patients can absolutely still receive supportive care from a palliative medicine specialist. And we have numerous studies that show these patients actually have a better prognosis, and their chances for a longer life or even a potential cure are higher. But also from my point of view, it's really important to offer this care to these patients so that they're going to have a better quality of life, and they're just going to be more comfortable, happier during the whole treatment process.
Okay. So I want to have like a defined picture of it. So if a patient, for example, just got diagnosed with congestive heart failure, at what point should they immediately start, while they're taking their medications for the congestive heart failure, at what point do they need palliative care medicine? Is it at the beginning, or is it maybe when the disease has progressed to a certain point?
What I will tell you is that when we're talking about the newer concept of palliative medicine, generally we're talking about initiating palliative care, palliative medicine at the point of diagnosis of this life-limiting disease, be it congestive heart failure or be it pancreatic cancer. The thing is that our role at the beginning is going to be quite small. So we're talking about maybe seeing these sort of patients in an outpatient clinic once every few months to sort of see how they're feeling, how are their symptom control looking like, and as time goes on, then our role is going to become more and more going to become larger. We're going to become more involved in the patient's treatment because, of course, as the disease progresses, generally the patient's symptom burden is going to become more and more intense. Congestive heart failure, it's good you mentioned this because this is a disease which is becoming more and more prevalent in our society. It's also, I think, an area of greater and greater interest in palliative medicine. However, this can often be difficult when we're talking about the chronic diseases, especially organ failure, because of the whole trajectory. So with this trajectory of things like congestive heart failure, COPD, it's generally characterized by exacerbations and then by sort of intensification of treatment, hospitalization, and then sort of an improvement in the patient's general condition. So it can be difficult, for instance, for our colleagues, pulmonologists, cardiologists, internists, to really say at what point we need to be thinking about intensive palliative medicine. This is where the palliativists can really be helpful when we're talking about having them involved in the whole process from the very beginning, because we can sort of look and assess the situation with a sort of a different pair of eyes. And then when we see the patient's status deteriorating, and when we are starting to look at the patient as being a patient with a much poorer prognosis, a much shorter prognosis, we can, for instance, then be talking with our colleagues and talking about, maybe it's the time to think about less intensive cardiological or pulmonological treatment and more of a symptomatic sort of quality of life approach. In the case of patients with cancer, this is, I would say, a bit easier because these patients usually have a much higher symptom burden from much earlier in the disease course. And this is where we also really want to be thinking about palliative care from the very beginning. This, I mentioned earlier, supportive care, so that these patients can have their pain, dyspnea, nausea, and vomiting under control through the whole treatment process. Because again, not only is this going to give them better quality of life, but it's also going to help the oncologists offer the patient more effective treatment.
Okay. You keep mentioning quality of life. A lot of people can understand that in different ways. They can understand that as maybe, I don't know, in any way they could understand it. But what is quality of life in that sense? What is improving a patient's quality of life? What does that look like?
It's a very good question. I will tell you that you're absolutely right. Different people understand quality of life in very different ways.
Yes.
The same thing as patients also understand quality of life in very different ways. I would say that when I'm talking about my field, quality of life is sort of achieving the best life possible for the patient while keeping in mind the reality of the situation. So sort of the best quality of life under the circumstances. Because remember, quality of life for you and me is maybe having a free Saturday to come here and talk to you and not being working constantly in the hospital. But quality of life to a patient who's bedridden, who is, slowly dying of pancreatic cancer, maybe a good quality of life for them is not having pain and being visited by their families once per day. So you really have to look at each situation differently. I would say individually, and look at it, and also, talk about it with your patients and their families. What do they want to achieve? What are some of their goals for the end of life? And how can I, as a physician, help them to achieve that? Of course, there are certain measures we look at, things like symptom control, things like pain, dyspnea, again, even things like bowel movements. Having a regular bowel movement can have a great impact on the patient's quality of life. But also we want to be thinking about the psychological state of the patient, also the social issues as well. It's very important in palliative care. We're thinking about, again, quality of life is, I would say, the most important word in our dictionary, but I would say maybe the second or third is going to be holistic, right? We want to be looking at the patient and the situation holistically and try to be focusing on all the different spheres of the patient's well-being, not just physical, but also psychological, social, emotional, spiritual. So I don't have a good definition for you. What's important is that we're going to be assessing this sort of on an ongoing basis and trying to achieve the best existence possible for our patients who are suffering from very serious disease.
Yes. I like that you mentioned that quality of life, improving the quality of life cannot only be medical sometimes. It can also be spiritual and psychological. And all this is also included in the palliative care, So how do you, maybe from the medical aspect of treating the symptoms, which I'll also ask about what kind of symptoms you're treating in palliative care, but aside from it being medical, how do you deal with the psychological part of it? What do your patients need, and what are some of the wishes or some of your patients' quality of life definition?
Regarding symptoms, so of course we as physicians and medical students, we're always thinking about the physical medical symptoms. So, we're working with patients suffering from pain, dyspnea, nausea and vomiting, cachexia, diarrhea, constipation, anxiety, depression, also things like disturbances of consciousness, psychiatric disturbances, all of these things. But really, we're also responsible for assessing and trying to help patients with all of these other spheres as well. So this is where, regarding the psychological issues, what can physicians do? Physicians, of course, can assess and think about, does my patient need sort of extra psychological support? And another thing is palliative medicine is really a team-based specialty. So physicians are, of course, sort of the leaders of the team, but nurses are incredibly important. Psychologists are incredibly important. Physiotherapists, social workers, chaplains. It's a whole team that's going to be taking care of the patient. So my job as a physician is, for instance, to assess whether my patient needs sort of more intensive psychological support, and then I'm going to refer them to our psychologist for a conversation. But there's also a lot of things that I can do beyond sort of assessment. So I can also try to be focused on the more human aspects of our patient's life. I always try to talk with my patients about various things, ask them what they're reading, especially if I see a book on the table, ask them how they're feeling, maybe ask them about their grandchildren as well. This adds a very human element to the medicine. And this is can really help patients from a psychological, but also I would say in sort of existential point of view. And these things. Remember that many of my patients are bedridden. They are, to be put bluntly, they are lying in bed waiting for death to come. This, from an existential point of view, can be extremely difficult to cope with for them, especially if this is a younger patient, a patient who is very active. This is their whole existence has been sort of flipped upside down. So focusing on these human aspects of it can be extremely helpful. For instance, this is also why I like going to patients with students. On one hand, sometimes, having students examine the patient from head to toe can be quite burdensome for the patients, but many times even classes with students can have a positive effect on the existential suffering of our patients, because they feel now that they can still be of value to society, right? They can help to teach the future physicians. They don't feel so isolated and sort of, worthless that they might feel otherwise. So these sorts of things. Many times also, I would like to point out here that I get questions, what do you say to such a patient who is dying and depressed and dealing with all of these existential issues? And my answer is many times nothing. Many times it's much better to listen to them rather than to say something. And there's this sort of technique in palliative medicine, which is called deep listening. So when we're talking about deep listening, I'm just listening to the patient. I'm listening without trying to fix anything. And even this listening to the patient's concerns, to their fears, can be extremely therapeutic for them. And it can also give me many insights as a physician. What sort of areas can I focus on when trying to improve my symptomatic treatment of this patient?
The listening part, I like that you mentioned that, because even aside from being a physician, even maybe their family is dealing with them. For example, if a family is having someone in the close family that has is terminally ill, sometimes they don't know what to say to them. They don't know what to tell them. Should I give them hope? Mm-hmm. Because again, there's maybe not hope of the cure. Mm-hmm. So what exactly do I say to them? I think these are very difficult interactions or conversations people find hard. And from a patient point of view, they view it differently. So from dealing with terminally ill patient or very vulnerable patient, what have you seen they want more from people outside looking at them? Because a patient going through chemotherapy or going through already knows that they're probably going to die soon. They would probably need a different approach to them. From dealing with them, what do you think, what is the best way to support this patient, both from a medical point of view and a human side of it?
I will tell you that I think, being present is really important. Being present, but also not being afraid to touch various issues. So we also talk about in palliative care this sort of conspiracy of silence. When the family, all the close people for the patients, friends and family, sort of are conspiring together, they're all afraid. They don't want to talk about it with the patient, so they don't talk about anything. They don't touch any of these issues surrounding death and dying. And as a result, the patient actually starts to feel even more isolated than previously. And you mentioned here that, yes, many families are sort of very eager to sort of stop the conversation, sort of give false hope to the patient, and they're not really available to the patient to have a discussion about death, dying, what's going to happen during the whole process. And many of our patients actually want to discuss it. They discuss it with us very frequently. And many times they also would like to discuss certain issues with their families, but families are sort of afraid. And rather than letting the patient say what they want to say or ask certain questions, they say, no, everything will be fine. And they change the subject. Or many families here, especially in Poland, will focus on feeding the patient, right? So they'll bring lots of food, try and force feed them, because if the patient is eating, he's healthy. And if he's eating, he can't talk, right? So we don't have to talk about such issues. These issues are very, very difficult. They're very difficult for me to talk about them as a physician. They're even more difficult for families to talk about when this is your loved one. However, they are very important. And we also want to be focused on the fact that when we're discussing these issues and sort of resolving these issues, this can be very helpful to the patient, psychologically, spiritually, but also even somatically. We see that all the time. So I usually talk with families and say that, it's mostly up to me to talk about the prognosis and the various medical issues with the patients, but it's also up to them to not sort of shy away from such conversations, and also not to build up this false hope. Our job is sort of to come to, we want to sort of help the patient and the family come to terms with the reality of the situation. But of course, you have to do this very slowly, very gently, with a lot of empathy, so as not to simply completely destroy the patient's psyche, right? Yes. And this takes years of practice. It's not easy, and this is also something that's very difficult for young doctors. medical students also as well. But with time, you really have to be open for conversation, for honest conversation, and really try and build up this patient-physician relationship.
Mm-hmm. I like that you touched on that, because I wanted to talk about communication in palliative care as a topic itself, because I know it probably looks different from other medical fields. The way a palliative care doctor is going to talk to a patient or examine a patient is different from how a cardiologist is going to examine a patient, for example, or a dermatologist. So communication being a very key point in this specialty. First of all, how different do you think it is to communicate with a patient, like your patient interaction? How different is it from other specialties or other fields? Because you also work as a general practitioner, so I feel like you have both sides. How different is it?
I will tell you that what you mentioned is about dermatologists and cardiologists talking differently with their patients than we do as palliativists. And this is true, but it shouldn't be, right? And really, we should be able to have empathetic, open, honest conversation with our patients, no matter what specialty we're in. I would say, though, palliative care specialists have the most practice in it, because it's something we do every single day. It's also, these conversations are involved. They're also included in our training program. But I would say also, many of these especially difficult conversations come to us because of the fact that our other colleagues maybe did not have open, honest conversation at the beginning. So now we're approaching a situation where the patient doesn't know the whole truth about their disease. It hasn't necessarily been explained to them at an earlier point. And so we get lots of practice with these very, very difficult conversations.
And these difficult conversations also involve breaking bad news.
Yes.
Do you find yourself being the doctor to break the bad news? For example, if a patient is being diagnosed, they're being sent to you from our cardiologist, for example, or oncologist. Do you find yourself being the doctor breaking the bad news or telling the patient about their prognosis? Or is it usually they already know, they come into the palliative care department when already knowing what their prognosis is like?
Unfortunately, many times I am the one to break the bad news to this patient, and they don't understand fully their prognosis. And there are, of course, some colleagues who simply don't want to have these conversations, and they sort of kick the can down the road, and it's easier to just sort of, throw this onto me than to have the discussion with the patient themselves. However, many of my other specialists, they try to have these conversations, but it's not always understood by the patient. My other colleagues also sometimes don't have time to have these difficult conversations. And they also maybe are lacking some of the training and some of the experience in having these conversations. So it's not always, because of ill will that this patient comes to me and they're not really fully aware of their situation. But this is, of course, something, it doesn't really matter when they come to me. It's up to me to help the patient and help the family come to terms. And to have this breaking bad news conversation with them.
So breaking bad news is hard, both for the doctor and also for the family as well. The family side, I'm talking about it because I know, for example, back home, a lot of people are afraid of having these conversations, especially if the patient is young. If a parent has a child who's, for example, terminally ill, sometimes they even hide it from them. They are not open to having these conversations. The doctor will talk to them and tell them the true honesty of the prognosis. Maybe the patient has a few months left, but the parent feels like they shouldn't tell this to the child, or even doctors, they're afraid of what's the right way to break these news to a person. From your experience, could you tell us the best way to, not the best way, because there's not a right way of saying these things to a parent or to a patient, but what is the most appropriate way to go about telling such news to a patient? And I also want to quote one, not quote, but kind of tell one of the experiences I had in third year. I remember it was my first time being exposed to very vulnerable patients, because that's the time we start clinical classes. So I was in the internal medicine department, hematology. So I was seeing a lot of leukemia patients. And I remember we were talking to the doctor, and she mentioned how one of the patients had like a few months left. And it made me question, first of all, how open is the patient to knowing how long they have left? They can know about their prognosis, their disease, and how it has progressed, but are they usually willing, or do they really want to know how long they have left? Should the doctor go ahead and tell the patient how long they have left, especially because some patients will be like, oh, you're not God. How do you know that I have this time left? But from that point of view, I was just questioning, would people be willing to know? Is it the best thing to tell them how long they have left, or how bad their prognosis is? Is it worth hiding it from them?
I would say absolutely it's not. It is not worth hiding from them. As a physician, and I've seen many patients who, for instance, the prognosis was hidden from them by their previous physicians, be they oncologists or surgeons. And usually these patients have, I would say almost always, they have a lot of regret and a lot of disappointment when thinking back to their interactions with this physician who did not have the appropriate conversation with them. Remember that these conversations are very difficult. They're not easy. And many of us are afraid or not very eager to have these conversations. But what is important to remember that we are doing this in order to help the patient. Many young physicians have this sort of feeling that if I break this bad news to the patient, I am sentencing them to death, right? It's my decision, but it's not. It's not. Unfortunately, this is how the reality of the situation looks. Our role as physicians is to help the patient confront the reality of the situation. It's not our choice that the patient has an incurable disease. We did not fail in our treatment. This is simply how the reality looks like. And patients also many times, they feel it. They know something's wrong. And many times also they know that something's being hidden from them. And in general, patients want to know about their prognosis and also about how long their predicted survival is. This is also important when we're thinking about assessing, why does the patient want to know? Is this because of a special event they're waiting for, a wedding, a christening, or is this simply because they want to put their affairs in order? And also by sort of hiding this information from them is absolutely not going to be helpful, neither from a social or psychological point of view, but also from a somatic point of view. When patients have not been informed, have not had the time to come to terms with their disease and their prognosis, these patients tend to die with much more suffering than patients who have had time and the space to sort of talk about issues and come to terms with the situation. So this is very important. When we're talking about patients, and my advice to young physicians and medical students, when the patient asks you how long they have to live, we don't want to be giving them a statistic or an exact time frame such as 3 months. Many patients in the stress of the moment could take this very literally, that they will literally die in 90 days. So on the 7th of September, right?
Yes.
If we're talking about today, the day of filming. But this is not helpful for the patient. Think about it. If I tell my patient they're going to die in 3 months, two things can happen. The odds that they're going to die in exactly 90 days is very, very small, right? So the patient can either outlive my prognosis, live longer than 90 days. This then sort of undercuts their confidence in me. And this can also maybe be motivation for the patient to question my medical judgment in general.
Yes.
Maybe Dr. Smith was also wrong about his prognosis. In his diagnosis. Maybe I don't have cancer. If the patient dies before the 3-month mark, well, this can also cause anger in the family, right? That you lied to us. You told us the patient had more time.
Yes.
This is why we want to be assessing why the patient wants to know. Is this because of a special event that we need to be either helping the patient modify the date, or this is what we want to strive to? And we want to be thinking about sort of giving the patient time frames which are going to be vague yet specific, which sounds, of course, like an oxymoron. But what I'm talking about here is talking about a time frame such as, I'm afraid it's a matter of months rather than years, or it's a matter of weeks rather than months. This is usually enough to let the patient know and the family what sort of time frame we're talking about. And this is usually enough to help the patients start to be able to make choices about how to spend the time they have left.
What in that case, what about patients who have their guardians in charge of them, children? Who do you break the news to? Is it the parent? Is it the child?
I do not feel I am competent to answer your question because I do not work with children. I only work with adults. The whole issue of pediatric palliative care is even more difficult, of course, because we're talking about dying children. In this case, as in all cases in palliative medicine, it's also very important to assess the situation individually and to think about how old is the child? Does the child want to know? Is the child asking you questions? So this is not an easy question to answer.
Yes,
this is unfortunately outside of my competencies.
Yes, I understand. So also working as a palliative care doctor, it comes with a lot of ethics, practicing in ethics, which also comes with like a lot of patient autonomy, and those, because you're not dealing with one person, you're dealing with the patient and also their families. What are the most challenging parts of, like, the biggest challenges of dealing with a patient, the wishes of the patient, socially, spiritually, all of that? How do you deal with that, but also their families as well?
Yeah, when we're talking about the ethics at the end of life, what's important to remember is, of course, we're taking a holistic approach. We're not only considering the patient, but also the family. But at the end of the day, the patient is always number one. The patient decides. The patient can say, no, we need to be focusing on the patient's well-being. If this corresponds to the family's wishes as well, it's perfect, right? The problem is then when it comes to a conflict, and when the patient's well-being starts to be in conflict with the family's wishes. And from an ethical point of view, again, patients are the most important. They make the decisions, and we as physicians need to be providing our treatment in accordance with the patient's best interests. But it can be very difficult.
Yes. Do you usually find yourself in the middle of both the patient and the families? And if you find yourself in such a situation, obviously you're going to choose the patient, but sometimes you're also dealing with the family as well. So how do you try? Is it your role to try to convince both of them, or do you let them deal with it, sort of?
I would say that our role is absolutely to try and help them to come to a consensus. Also, for instance, this is where the psychologist comes into play here, because they have special training and knowledge in such interpersonal conflict. But it's also, I would say, very important for us as physicians to set boundaries with families. This can sometimes be very difficult, but we need to set boundaries with families. We need to tell them that the patient is most important here, because sometimes they seem to forget about it. Because of course, or simply, they have their own issues as well during this whole process, and their own experiences, and these are coming into conflict with providing the best possible care for the patient.
With this interview, I definitely want to talk about the COVID period time, because I feel like practicing during that time was probably different from practicing now and before then. Could you take us through the COVID experience as a palliative care doctor? What was that time like?
I will tell you that I was still a resident during the pandemic, so I didn't have all the responsibility some of my colleagues did, but I was sent to the front, as I like to say, and I was working on a COVID ward, which was generally for the patients who really didn't have much hope. So it was very, very palliative care oriented, and we were really focusing mostly on comfort care, relieving symptoms, and ensuring a peaceful death. However, the COVID area was very interesting from an ethical point of view. All over the world, we started to find out that our medical systems are not adequate to deal with such a great crisis. COVID was a war situation, right? And we had to then choose about which patients to try and save and which patients not to. So we as palliativists were involved in some of that decision making. We had panels of physicians who were looking at patients and who was going to be a candidate for intensive care and who was not, based upon not only their age, but also all of their comorbidities and their realistic chance for survival. This, of course, is not easy, and we don't really see this right now, but, during COVID, we didn't have enough intensive care beds for everyone, enough respirators. So you very oftentimes had to choose. You had two patients whose general status was worsening, and you only had one intensive care bed. So who gets the bed? And I think this is the palliativists like myself were also very helpful, because we tend to look at situations a bit more realistically as to a patient's prognosis. We sort of offer a different perspective. But it was a very difficult time.
I'm curious to know, on that point of choosing who takes the bed, is that something that is already written in the ethics book, for example, or is that generally, not even maybe in the palliative in the COVID period, is that something that is already told what you do in that situation, because that situation could also happen, especially in countries where they don't have much resource. You could receive a patient and know, maybe two patients, and know that you have maybe one respirator. Which patient gets that? So how does that decision come about? Do you obviously you look for the comorbidities, but how does that decision come about?
It's also important to remember that when we're talking about such issues, we have to be working in accordance with the laws and regulations of our jurisdiction.
Yes.
Generally, however, in medicine and in most medical ethics code, including the Polish Code of Medical Ethics, futile and persistent therapy is not allowed, right? So we're not allowed to give our patients futile therapy for various reasons, mostly also because this is not going to be helpful for the patients. This is why, for instance, we do not resuscitate patients with metastatic cancer, right? We don't resuscitate them and send them to the intensive care unit because of the fact that this is going to be futile therapy, which is only going to sort of prolong patients' suffering without any clear benefit to the patient. But what's more, it's also going to be detrimental to society. When we're thinking about medical ethics, there's this aspect of justice, right? Justice. So trying to use our limited resources as equitably as possible. Here in the Western world right now, I think when we don't have COVID, we don't have such a big issue with limited resources, but it is still an issue. Right? We don't have an unlimited amount of blood or intensive care beds. So we are trying to look at the patient sort of holistically with other specialists as well and think about, does this patient qualify for intensification of treatment? Will the patient benefit from intensification of treatment? Or not, right? Because many patients simply will not. And we make the decision that certain interventions are futile and persistent therapy.
Yeah, I agree. You talked about, at the beginning of this interview, you talked about your experience with your grandfather having Alzheimer's disease and you wanting to help. One thing I used to think about, maybe before I got exposed to palliative care medicine, was I used to think if, as a doctor, you're supposed to cure a patient. And if you don't find a cure, if you don't find something to help, to cure the disease, you have failed the patient. So that made me look at death as a failure. So you, from the beginning of you choosing to study medicine to now, has that experience changed the way you view death and medicine?
I think it does. Often sometimes I joke that I work as a general practitioner twice a week to sort of be a real doctor, right? So not a doctor of death, but a doctor of curing patients.
Yes.
But we need to remember that, palliative medicine has only existed as a specialty for, in Great Britain, Ireland for much longer, but here in continental Europe, in the United States for, a little over 20 years. But really the whole idea of physicians taking care of dying patients, this is one of their oldest obligations, right? I mean, a long time ago, physicians were mostly sort of ministers of death that just sort of help patients along through the dying process. So what we're doing in palliative care is absolutely not new. What's, I think, happened is that medical technology has advanced so much that we've sort of forgotten that patients die. and that medicine is not able to cure everyone. This is not only true for physicians, but for the general public, right? They see all these great new surgeries and new treatment techniques and new drugs all the time, and they don't necessarily understand how many people die of cancer, of congestive heart failure, COPD, and what have you. And this is also then built into our medical system. When medical students come, they also have sort of unrealistic expectation. What is medicine? And this sort of is built and built and built, that the role of a physician is to cure disease. This is it. And of course, this is the primary role, absolutely. Yes. But we exist for those patients who do not have hope for a cure. And this is also why I love having classes with students, because I am able to show them that, patients die. Patients die. And when, as physicians, we are unable to cure them, the most responsible and most beneficial thing we can give them is symptom control, right? Symptom control and good quality of life.
I remember the first time I came to the palliative care ward. It was in third year, and it was an internship with you. And that was, I would say, maybe the first time I was exposed to death in that quantity, because I remember I would see a patient today, and then the next day when I come in, he is not there. And then I would ask you, where is the patient? Say, unfortunately, he's passed on. So that had like a huge emotional toll on me, because again, I'm still a student. I still feel like I haven't accepted or felt like death, which is a common thing for people not to accept or taken death as a reality, something that would happen. That has, on your perspective, on your experience, does dealing with death a lot, does that have a huge emotional toll on you? Or do you feel like with years, you've kind of gotten used to the feeling of it?
I will tell you that, of course, I have gotten used to it, even numb, I might say.
Yes.
Especially when it comes to patients. So remember that I lose patients all the time.
Yes.
And, you do somehow get attached to certain patients. There are certain patients you especially like. But you really can't get attached, and they die, and the next patient comes. And I don't necessarily get attached to them anymore, because of course you can't in my field. You would not survive. Yes. But from a personal point of view, thinking about death all the time is, and being exposed to it is also, on one hand, it's a positive, because it makes me think about and focus on things that are actually important in my life. It also helps me not to delay gratification too much. We as medical students and young doctors, our whole existence is about delaying gratification. And when you're working in palliative, you start to think that I can't delay it for too long, because I don't know how long I'm going to be here. I think also there are certain cases, especially when you can identify with personally, that are especially difficult. So, if you're seeing someone who's your age, watching their spouse die, you're thinking about your own spouse dying, or vice versa. So absolutely, it's difficult. It's difficult psychologically, but it also has some positive impact on my life as well.
Earlier on, we mentioned about alleviating symptoms of patients, and some of those symptoms can be pain, because I know a lot of patients, for example, with cancer, some cancers are very aggressive and they're very, very painful for the patient. And this is where palliative care comes in, where you're trying to to alleviate that pain. Do you always feel like with your patient, this goal is always achievable? And to what degree is it achievable?
I would say, in some patients, it can be difficult to achieve, 100% symptom control. In some patients, it's impossible, simply. But we really have a lot of tools in our toolbox. Also, when we have a patient with very, persistent somatic symptoms, intractable, that we cannot treat, then we always can offer them palliative sedation, which is when we essentially lower their level of consciousness pharmacologically, so that they're not going to be experiencing these symptoms, which are simply treatment resistant. But this is rare, but it does happen. It does happen that, unfortunately, achieving adequate symptomatic control, is very difficult.
Yes. From this question as well, for example, you mentioned that sometimes it cannot be 100% achievable, and having those cancers, for example, or those diseases that are very painful to the patient. Have you ever received or had a patient who has wished euthanasia on them? I know this is a very controversial topic, and not a lot of people want to talk about this, but it's a reality that maybe you can find a patient that is maybe in too much pain. They will ask the doctor, can you please help me? Could you tell us a bit about that?
Yes. I have had the topic of euthanasia being touched upon by certain patients. What's also important to remember that usually when the patient is asking for euthanasia, this is also, to some extent, a cry for help, and also a very strong signal for me as a physician that I need to assess my treatment and make sure the treatment is optimal. Many times also when patients are asking for euthanasia, it's not necessarily an issue of somatic symptoms being not under control, but even existential symptoms. Existential and psychological suffering can be very, very difficult in such patients. I think a lot of the desire for euthanasia, both individually and also in populations, is because of inadequate palliative care, either on a societal level or on a personal level. That simply patients are not receiving proper specialized palliative care. It's very rare that I am unable to control a patient's symptoms.
Because I know some countries have taken this into their medical system, where a patient can ask for euthanasia. So I wanted to have like a perspective on that from a person who deals with a lot of with patients that are in a lot of pain. But with that, I also wanted to, I think I forgot to ask you the journey of palliative care residency. What does that journey look like? How many years is it? And with each step of the year, does that look different?
In my case, it was 5 years, and this was 3 years of internal medicine training, both general internal medicine and subspecialties such as cardiology, pulmonology, gastroenterology, and what have you. And then it was 2 years of specialized palliative medicine training.
Okay.
So both on a hospital ward and also in home hospice. So, and then of course, a very large, difficult exam at the end.
Oh, a very difficult exam.
Yes.
Is that like a palliative care exam or an internal
palliative.
medicine?
So this was the state specialization exam in palliative medicine.
Do you feel like it's a very demanding specialty?
It is demanding, but it's also very rewarding. So I think there are other specialties which are even more demanding and less rewarding. So
one of the reasons why I even thought of starting this podcast is because a lot of medical students, after they finish med school, we have never practiced as doctors. So we don't really know unless you have like a huge instinct and you already know what you wanted. But a lot of us don't know what specialty we could get into. But like hearing it from a doctor or a person who's already into the field, you can kind of compare that to what you want, your goals in life. So I was also reading this book. It's called When Breath Becomes Air. Mm-hmm. At some point, he was talking about how a lot of medical students just choose, after their medical school, they just choose specialties that are less demanding, more money, less time. Yes. And he went on to describe how this can be stealing from medicine, the actual medicine, because, for example, if you want to be an ophthalmologist, for example, or a dermatologist, not to say that this specialty is not contributing to medicine, but you get very few, maybe not very few patients, but compared to, for example, internal medicine, there's few patients in dermatology. So I think that's why he was saying it's stealing from medicine. Mm-hmm. But again, people have different goals in life. Yes, of course. So to your advice to someone thinking of a residency, mm-hmm. would you advise them to go for palliative care medicine? Do you feel like it has a good work-life balance? What does that look like? What would you mm-hmm. advise that person?
I think the work-life balance, you can achieve it. Mm-hmm. You can also not achieve it. So the problem, especially with palliative medicine, is, it's difficult to say no. So I have this problem in my home hospice job that, there's always can you take one more patient? They're in a lot of pain or this and that. And you sort of find the situation spiraling out of control and you can't say no because, this isn't as someone who's coming for cosmetic surgery or whatever. This is a patient who's dying and who needs help. So you also sometimes have to set boundaries, and this can be very difficult from a sort of ethical, psychological point of view. Palliative is extremely also demanding psychologically, emotionally. It's kind of like, choosing to become a priest or something like that. Mm-hmm. It's really more of a life choice rather than just a specialty. And you're also going to see some things in palliative medicine that you're never going to be unable to see. So it's sort of like once you start down that path, you're sort of stuck with it, right? Mm-hmm. Because also from the point of view that you start to think about how important you are for your patients, but also that you start to think, you couldn't do anything else with your life. So I think sometimes that maybe, I'll quit palliative and just become a GP, right? Mm-hmm. But then I know that this is never going to happen because my patients need me. And it's simply, this is the path I have chosen and that's it.
Mm-hmm. Do you think prior to going into palliative care medicine, you have to have some sort of emotional intelligence, or do you think anyone can go for it and it just trains you as you go?
No. This is a very good question. I think that you absolutely have to have a certain amount of emotional intelligence and a certain amount of empathy. If not, I have met doctors who, in my opinion, have a low emotional intelligence, but are palliative medicine specialists. And I don't think they're good palliative medicine specialists.
What would you define as a good palliative care medicine? What qualities should they have?
Of course, they have to be empathetic. This is really important. But also competency is important as well. So they have to look at the patient holistically, have a really good approach, good bedside manner, but also have a good understanding about the whole pharmacology and the symptomatic treatment and things. It's not such, on one hand, it's not maybe neurosurgery, but it also is quite difficult, especially, and you also have to know what you're doing from a sort of medical point of view. I think that there can be many different good palliative medicine specialists. It's a difficult question to answer. It's very subjective, and I think, maybe summing it up, a good palliative medicine specialist is one who always strives to give the patients the best quality of life possible.
Yes. What are some of the wishes you get from your patients? Do they, for example, do patients prefer to stay in the hospital near doctors and near nurses, or do you find more of your patients want to spend their last days in their homes?
It depends. Some patients absolutely want to be at home and want to die at home. Other patients prefer dying in the hospital, and this is their goal. So there's really no rule of thumb for it. But what's really important here is that you discuss these preferences with your patients and with your families. So when I have a patient, for instance, when I'm admitting a new patient to home hospice, I always try to have this discussion. Do you want to die at home? Because if you say yes, if they say yes, absolutely, I want to die at home, this helps let me know where we stand and helps me to modify my treatment to achieve this. If the patient is a bit more, ambivalent about it, well, then I know that the hospital and dying on a palliative medicine ward is also an option. So it's another question about, can I, as a physician, adequately control the patient's symptoms at home? Because I don't want a patient to die at home, but while suffering terribly. That's not what it's about either. So I need to look at this as a physician, honestly and objectively. Can I achieve a good death for this patient at home, or do I need round-the-clock medical care?
And these questions, is it like a formulated questionnaire that you have to ask these questions, or does that come from you being as a doctor?
Yes, this comes from experience. This comes from also working in both settings of the hospital and the home hospice, because I know what it looks like from the other side as well. There's no real guidelines in palliative medicine. It's very, very rarely do we have guidelines. So there's no algorithms. We really have to be thinking about each individual situation and how to achieve the best outcome.
Great. So now we're kind of leading towards the end of the podcast, and I know I didn't ask you this question earlier, but I'm also very curious to know, because you are working very many different fields. You're working as a general practitioner. You're also working as a teacher and also a chief palliative care specialist. What does a day in your life look like?
Very well. My primary employment, my primary position is, of course, as a palliative medicine specialist and the vice chief of palliative medicine on our ward at the Jagiellonian University Hospital. During this time, I'm also oftentimes will have classes with students, either formally organized lectures or also more informal bedside teachings, summer clerkships and things, clinical rotations. I'm also usually responsible for having residents and some interns which are rotating through palliative care, who are not only helping me, of course, with my daily tasks, but I'm also helping to educate them as well. So my day in the hospital is extremely chaotic. And generally when I then finish at the hospital, I will either go for a home visit to a patient in a home hospice, or to my GP practice, where I will see general medicine patients.
Okay, must be a busy day, very busy day.
It is.
But you also find a way to balance it with your social life.
Yes.
So how do you balance both the professional and social life as well?
This is important. For instance, I don't work on weekends. I could, and I used to previously go visit palliative patients, home hospice patients on weekends. I no longer do that. And, it's important for you to have this balance to be home every night for dinner later, but still, and to sort of have your little rituals that, to keep this balance.
I think that's a very nice way to balance, because at least 5 days on, I'm working, and then I'll have something else to look forward to. But have you been able to achieve this after you became a specialist, or was that also possible during residency?
No, this is definitely as a specialist, because then as a specialist, you can also sort of, you can very easily set boundaries, especially in palliative care, because there are so few of us. So really there's, if they lose you, there's no one to take your place. So, but this is difficult. And sometimes you feel, at the beginning when I started setting boundaries, I felt sort of like I was a poor doctor, that maybe my patients were losing out or whatever. But then with time, I came to terms with it, knowing that this is necessary for my health, so that I can continue helping my patients.
I asked this because I know during residency, some specialties are very demanding, to a point that residents literally stay in the hospital almost 24/7, Monday to Saturday. So during palliative care as a resident, as a specialty, going through that residency, is it very demanding to that point, or what does that look like?
What you're describing also is, I think, residency in systems which don't have such labor protections like in Europe. Generally in Europe here, the most they can force you to work as a resident is 48 hours per week. So obviously this 24/7 in the hospital it's illegal. But
is that for every residency?
Yes, for every residency, for every physician. If you can sign a document that says that you consent to working more hours per week, but this is your choice. You cannot be forced to do it. So many people do, especially if they're working in places where that are understaffed. In palliative medicine, we are understaffed, so it can be quite also demanding, but maybe not the most demanding.
And that sort of brings us to almost the end of this podcast. But before we end that, I would like to ask you to kind of give tips and advice to a different set of people. First of all, I'm someone thinking of joining the medical career. What should they prepare for mentally and emotionally? Also, that as a palliative care residency, someone who's thinking of residencies, what would you advise them to go for? So that's a medical student, and also someone who's just finished medical school.
My advice is to remember that it's a very big decision. You're going to sacrifice a lot to become a physician. Absolutely, you cannot do it for money. Of course, doctors make a good amount of money. We have a very comfortable financial life, but the rest of our life is not comfortable. It's extremely demanding job, and you really have to know what you are getting into before you start. Really, you're going to be a doctor first, and you're going to be a husband, father, member of society, second, third, fourth. You're always going to think about yourself first as a physician. Which is not healthy, but that's how it is. Also remember that medicine is a field that's very difficult to leave. I think from a technical point of view, but also from a psychological, ethical point of view. So really, when you're make the decision to study medicine, this is going to be your life. It's really not going to change over time. And you can't just switch to another profession. The same thing also with specialties. It's kind of the same thing. It's difficult to change from one specialty to another. I mean, maybe if you're already an internist and then you do cardiology and then you want to do another internal medicine specialist, okay, fine. But changing from one vastly different specialty to another is not going to work. And the same thing as you mentioned here, don't only think about money, about work-life balance and having an easy, less demanding specialty. It's also very important for you to have this passion for what you do. And this is something I'm blessed with, that, every day I know going to work, I'm making a difference. And every day I feel fulfilled. Do I feel exhausted? Absolutely. But I feel fulfillment. And this is really important as well.
Yes. That's very good advice. Thank you very much. You mentioned having the thing of money. And I know a lot of medical students come to med school thinking, oh, it's a nice paying career. But when they get in and they see how demanding it is, both emotionally, but also time, you invest a lot of time and money as well. So it's difficult. It gets difficult for them when they get here. So I think that's a very nice way to hearing it from someone who's already practicing, who's already gone through that. That gives you a whole different idea of it. But yeah, thank you so much for sharing your knowledge. This was very educated. This was very helpful to kind of see through the lens of palliative care medicine through you. I'm very, very grateful that I had you on the podcast. Thank you very much for being with us.
If today's episode made you feel inspired or a little less alone, share it with us. Tell us your thoughts in the comments. I was your host, Amira Owase, and I'll see you in the next episode.